Okay.
Okay.
You're being recorded.
All right, perfect, thank you.
Dr. Parsargani.
All right. Hello, everyone. Once again, my name is Parsargani. We're going to be talking about the evaluation of acute spinal trauma. I'd like to thank you all for coming here today and spending the time out of your busy days to come and watch this presentation. I know that you guys are all pediatric residents, and except you, Doug,
and Dr. Rao, who is an attending physician, and myself. Who's an attending physician.
And so to show my gratitude, I've actually added a lot more of the slides that have to do with pediatric care. So let's go ahead and start off. Before I do, if you guys have any questions regarding any of the slides, feel free to just raise your hand, stop me, and we'll go over it while we're on the slide. And if I can't answer the questions right away, I will make sure to get those answers for you before I leave here. So let's go over the objectives. Once we complete this presentation, I hope that we can be able to differentiate the difference between computed tomography and magnetic resonance imaging. And also like for us to be able to recognize the why the imaging modalities could be used for one reason compared to another, and determine what abnormalities radiologists look for, explain what imaging modality to use depending on what we are looking for, and explain that with reasoning. And lastly, create a guideline for creating a acute spinal trauma evaluation for the patients that come in via case-by-case basis. So let's go ahead and get started by talking about the difference in the two modalities. So as stated previously, we're going to be talking about mainly CT versus MRI in this presentation. We'll start off by going over the cost and time it takes to produce the image and the radiation dose of CT. We'll also be going over the detail of the images produced between the two modalities and what could happen if we use the wrong modality during evaluation. I'll also be going over diagnosing spinal trauma in high case patients like pediatric and pregnant patients. So let's start off. When evaluating a patient of acute spinal trauma, the typical procedure is to send them for imaging after evaluation. Now, the most common modality that is typically used in the emergency room is the CT. But why is CT our first choice? Can anybody give me a reason for why they believe CT is the first choice?
It's fast.
It's fast.
Faster, perfect.
Cheaper.
Yep, cheaper, great.
You don't have to check if people have metal implants or
Absolutely.
anything, and so if
Absolutely.
you don't have a historian to provide information, this
For-
is the safer way to go.
And
Absolutely.
for kids, you don't need to separate them. Yeah.
Fantastic, yes. Now, the most common modality is the CT, and it is in fact because of cost and time that they use this. And an emergency department, just like any other company, worries about productivity and they worry about how much money they can make. And because that is the main reason, they use CT, but that lack of detail that you get from some of these images may not be worth the cut in cost and time. So let's go over some details of the cost, the time, and the radiation dose that we get when using CT versus MRI. So according to Health Images, CT costs roughly half the price of an MRI. CT costing about $1,200 versus MRI costing roughly $2,000. Now, a CT scan of the spine typically takes 30 to 45 minutes for the scan to be completed, and that is from the time the examination room gets set up for the image and the time it takes for a accurate diagnostic image to be produced. However, the time that it takes for the actual image to be done is only 10 minutes. So the downside of using the CT is that radiation dose. And as we can see on the chart here, the CT of the spine takes 8.8 millisieverts of radiation in one image. Now, to put that into perspective, that's 3 years of background radiation in a matter of 10 minutes. which is a lot. And as we can see here, it is the highest dose exam done on a CT of the central nervous system. Now, this does increase the potential risk for cancer, and it's especially important in patients under the age of 5. Now, if we compare that to the information for an MRI, first of all, we don't have to deal with this chart because there is no radiation involved. It does, however, take longer for an MRI to produce an image. According to radiologyinfo.org, we have a window of roughly 30 to 60 minutes for a typical MRI of the spine. And if you were to add contrast into the study, that is adding another 10 to 20 minutes of time to the study on top of that, 30 to 60 minutes. Now, that does seem like a long time, but the difference that we are about to see in these next few slides when we're comparing these images will show you the amount of detail that we can miss if we were to use a CT when we should use an MRI. So here's a perfect example of that. You can see here an image of a 16-year-old male post-motorcycle accident, CT of figure A, and MRI. Now, this research study was done by Gamal for the Egyptian Journal of Radiology and Nuclear Medicine. Image A was taken using a multi-detector CT, and it is a sagittal image. And this image shows a disruption of the posterior cervical line with a small displaced fracture shown on that image with the white arrow. It also shows a fecal sac pointed out by the white arrow, and it's an increase in the interspinous space. And here it shows like double white arrow. Now, image B is a sagittal image done via MRI of the same exact patient. Now, we can see the same exact things that we saw in image A. We see the anterior and posterior longitudinal ligament, but we also see a compression of the spinal cord, shown right here. We can also see an injury of the ligamentum flavum and the interspinous ligament, which is noted here. Both of those which were missed when we used CT on the original study. So let's go over some essential elements in imaging spinal trauma. So the evaluation of imaging spinal trauma should be a case-by-case basis. The next few slides, we're going to go over those essential elements and how to diagnose these case-by-case scenarios. First of all, we do have to think about ionizing radiation as a carcinogen, and the use of CT increasing the possibility of malignancy. Now, there was a study that was done by the American Society of Radiologic Technologies on pediatric patients, and this study was on brain scans. Now, it showed that 1 in 1,500 kids under the age of 1 and 1 in 5,000 kids under the age of 10 had a chance of getting a malignancy due to radiation exposure. Now, let's put that into perspective. As we saw from a couple slides ago with the chart, the radiation dose that you get from a CT of the brain was only 1.8 millisieverts. Now, comparing that to the 8.8 millisieverts of radiation that you receive in the spine, you can basically assume that those numbers would be higher, especially for that kind of age group. Now, another concern is our inability to tell what will happen with the lifetime risk of a patient who gets CT exposure. Unfortunately, we don't have any studies done to it because we will not intentionally radiate any patient for a case study. What is also unfortunate is that our only basis of any studies that we've done was after we dropped the atomic bomb and the reactor malfunction, the nuclear reactor malfunction of Chernobyl. Therefore, it is important to treat the high levels of ionizing radiation from CT as a possible risk factor of malignancy. This reason alone should be enough to change our guidelines to use MRI technology for the evaluation of spinal trauma. So, what are some certain cases that you guys can think of that would have a higher benefit to risk ratio using a MRI versus a CT for spinal injuries? Anybody?
motor vehicle accident.
Yeah.
Perfect.
Yeah. So like looking for cardiac blindness syndrome and all
Yeah.
that, you would think you would need MRI, right?
Like someone who has like really severe neurologic deficits on our exam that we know that regardless they're going to have to have an MRI.
Any kind of possibility with a spinal cord injury also.
Looking for like cancer infiltrates.
Absolutely. Yeah.
Spinal cord infiltrates.
Absolutely. Okay, let's move on. And this was just an image that I thought, though it's not pertaining to spinal cord or any kind of spine injury, we've got a pregnant patient with burst appendix.
That's crazy.
Yeah. I thought you guys would enjoy this. So, we're going to be talking about the use of imaging in high-risk patients. Now, pregnant and pediatric patients are the highest risk when using ionizing radiation. Now, let's begin to talk about risk versus benefits in these kinds of patients. So, certain non-obstetrical emergencies will happen during pregnancy. And it is imperative for us to set guidelines to be able to treat or deal with these cases. Since the workhorse of the imaging department is typically the X-ray and CT, it is imperative to familiarize ourselves with typical doses that patients receive during these examinations. Now, from what we know, a fetal radiation dose that is less than 50 millisieverts has not been associated with fetal anomaly or loss of pregnancy. Now, that may be the case, but we still do have to think about trimesters. We do not want to put any kind of ionizing radiation at this kind of level during the first trimester, absolutely not. However, if it is end of second trimester, in the third trimester, this is acceptable. We can absolutely use this, especially after a motor vehicle accident, to make sure that everything is okay. Now, you can use this for ensuring that the patient is stable, but if you do need to repeat images for any reason whatsoever, after the CT has been done, it is advised to use an MRI, because we don't want to get anywhere near that limit where the fetus can be at risk, because we do have to worry about not only one patient, but a second. So let's talk about bone abnormalities and spinal cord injuries using CT versus MRI. So imaging technologies have improved greatly in the past 10 years, making abnormalities easier to visualize. Bone abnormalities are one of the most common things we look at when we are thinking about spinal trauma. And CT technology takes those images with great detail compared to our traditional radiography that you guys have seen, and that's because of the amount of penetrating power it takes to go through patient anatomy to make anything even close to a diagnostically valuable X-ray. Now, unlike conventional X-ray machines, which have a fixed X-ray tube, a CT machine produces an image using a narrow beam of X-ray that is rapidly rotating around the patient using what is called a gantry, which causes us to have such a better detailed image compared to that conventional X-ray, and that's why CT is used so often for finding bone abnormalities after these acute spinal traumas. So here we've got a case study that was done by Bernhard Tings regarding bone abnormalities, and this image was taken of a 24-year-old male post-mountain bike accident. Now, I know it is a little bit difficult to see because it is a regular radiograph and there was a lot of penetrating power required. You can see a T8 fracture right here, and figure B and C are the same patient, which was done via CT. Now, figure B is the mixed sagittal view and figure C is the parasagittal view. And you can see that there was a crush injury and posterior separation. So here's the crush injury. And the posterior separation is better seen in figure C right here. And from what we know, specifically with mountain bike injuries, they do carry a higher risk for spinal cord injuries at the same time. As you can see, we cannot see the spinal cord in figure B or C while using the CT, but looking at the MRI done of the same exact patient, we see that not only do we see the fracture that was seen in figure B, but we also see a spinal cord compression that would not have otherwise been seen in the CT alone. So let's talk about abnormalities in pediatric patients. Using a CT instead of a conventional radiograph on a pediatric patient increases the risk of thyroid cancer. The reason why I say this is that a typical CT has 14 times higher radiation doses than a typical radiograph does. And because the major issue in investigating spinal trauma in pediatric patients is the way that their bones are young and adolescent, and they are nowhere near what an adult's anatomy looks like, a CT will typically not be the best choice of action to use for being able to diagnose these acute spinal injuries. And Hutchins states that an MRI is a better alternative over CT because of that decreased muscle strength and the increase in the ligament laxity that are in that pediatric patient anatomy. So therefore, an MRI is a better diagnostic tool to depict valuable information for a better visualization of any spinal abnormalities in pediatric patients. The CT does have one really big advantage over an MRI. Can anybody tell me what they think that might be? And this has nothing to do with what you would see on a CT versus an MRI specifically.
Obviously, time earlier.
Yes, time. Perfect. That's where we're going with this now. Because motion must be limited during these examinations, a CT may be a better choice for interpreting for a patient that may not be able to hold still during that 30 to 60 minute time for an MRI. Now, if a patient's motion is an issue, sedation may be effective for a diagnostically viable image using an MRI. There is also new technology, my apologies, this keeps happening. There is also new technology called rapid MRI. Now, the rapid MRI, yeah, this is definitely something new. So,
And then my daughter got an MRI when
Mhm.
she got her knee injury,
Mhm.
and it took about 45 minutes to an hour.
That's not the
so
rapid one. That's
this new rapid MRI takes roughly 3 to 4 minutes
yeah.
to
Oh,
give
most
you the
definitely, that was
full
not bad. Yeah.
full spine series
Yeah, she got
in
through
3 to 4
it.
minutes with the same exact amount of detail.
Yeah,
Yeah.
you don't gotta worry about CRNAs.
It is, exactly, because that takes out the need for sedation. Now, I know that obviously none of you have this kind of technology in the hospitals that you may work at currently, because this is a newer technology that we have. Hopefully in the future this will be different. But if we do have to worry about this kind of stuff, a risk versus benefit factor comes into play again. We need to see whether it is a better option to do a CT. Go ahead. Yes.
How much does the rapid MRI cost?
I do not know
Yeah,
the cost
yeah.
the cost of rapid MRI. I literally heard about this for the first time 2-3 days ago, and I thought it would be an amazing thing to add into this, but I will look into it after we're done here. I'm assuming because it's so new, it's going to be much more expensive than that $2,000 price tag that we have for our normal MRIs right now. And that is probably the one reason why we're not going to see this kind of technology for a while. But as I was saying, risk versus benefit factors have to be put in to figure out if we're going to go ahead and use CT and MRI. We have to see whether getting a faster but less detailed image and also exposing the patient to ionizing radiation is a better option than sedating the patient for an MRI and possibly affecting the developing brain. So let's go ahead and talk about evaluation of cervical spine trauma. And when it comes to any kind of evaluation using ionizing radiation, radiation protection should be considered secondary after the examination of the patient. And this is especially important because the new guidelines for cervical spine trauma state that we should be using CT instead of traditional radiography. Now, The evaluation could be done using what is called the Nexus study criteria, which is the National Emergency X Radiography Utilization, and the CCSR study criteria, which is the Canadian C-spine. These two both help evaluate a spinal trauma prior to ordering a CT for a patient. Have you heard of that before?
What?
The CCR?
No.
No?
I
Okay.
just like things Canadian.
Fair enough. So do I, especially when it comes to these two studies. We do realize that it is much more.
Across the border. There's a lot of protocol
Mhm.
and stuff like that.
They did a really good job with this study criteria.
I like CCI's first one.
So let's go ahead and talk about the National Emergency X Radiography Utilization, which is a whole lot of words to say Nexus. Right away we can see that this is not a very, it's very simple. If the patient, by the way, this was made by Springer Link, this criteria here. When a patient comes into the emergency room, if the patient does not have any of these 5 criteria, the Nexus risk assessment dictates that the patient does not need radiography. Now, the original study was validated saying that this criteria had a sensitivity rate of 99.6%, which is an amazing number, but this number was later proven to be inaccurate, which we're going to be going over after the next slide. So before we get to the next slide, I wanted to kind of hand this guy out because it's a little harder to see on this TV.
You get a handout. Yes.
And this is the Canadian
There's
C-spine
actually
rule, which is
scary
much better. You get handouts today, yes. You can share. Okay, perfect. Yeah, you guys got handouts. There's 2 of them.
Yeah.
There you guys go. Thank you. Doug, you can Okay. So here we've got the Canadian C-spine rule. And the image above was made by Style in 2001. Now, obviously we can see that this is much more intricate than the first study criteria that we saw. But before we start looking into these categories, which go into these subcategories, I do want to go ahead and show you guys one thing right here on the top right. Most of your patients will be under the age of 16 for you guys. So the C-spine rule may not be an effective way to help you guys out for cervical spine injuries. But what we really want to look for is to first off make sure that your patient doesn't fall into this category. So no trauma cases, Glasgow Coma scale under 15, unstable vital signs, age less than 16, acute paralysis, known vertebral disease, previous C-spine surgery, and pregnancy. Now, if they do fall under this category, do not use this, use your judgment and do what needs to be done. But if they're not under this category, we're going to go ahead and start off with the top. And we're going to go ahead and go from the top. And while we're working up from the top, we're going to go ahead and look at the subcategories, which kind of explain what some of these main categories may mean. So the high risk factors requiring imaging are patients above the age of 65, paresthesia, which is numbness and tingling in the extremities, and dangerous mechanism. Now under dangerous mechanism, you see a little star. If you go down on the bottom left, you'll see what it means when it is talking about dangerous mechanisms. And those dangerous mechanisms are falls that are more than 3 feet or 5 stairs, a axial load to the head like a dive, high-speed motor vehicle accident, or a bicycle collision. So if the patient is not considered high risk, we then move on to the second category, which is any of the low risk factors you see below. Now, these factors are simple rear ends and motor vehicle accidents, which exclude the car being pushed into oncoming traffic, the car being hit by a truck or a bus, the car having a rollover, and being hit by a high-speed vehicle. Now, the patient being able to be in the seated position in the ER and being ambulatory is also another one. Delayed onset of neck pain is another one. And lastly, the absence of tenderness and a C-spine. So if the patient falls into this low-risk category, you're going to go ahead and move into criteria 3, which is to see if they have full range of motion. Now, if the patient has less than a 45-degree range of motion looking left and right, they go ahead and get a radiograph. But If they fall into category number 2 and have range of motion, radiography is not necessary. And I don't know what just happened, but let's go ahead and.
Maybe.
Oh, so take the link.
Maybe? Yeah, you probably clicked on the link or something.
There we go.
Nice.
Okay. All right. So now we're going to go ahead and compare the Nexus versus CCR, and this is the lovely thing that not a lot of people like: sensitivity versus specificity.
Look at this chart every time.
Well, great. Would you like to explain to us what this is? Thank you for saying something. Yeah. You want to go ahead and. Because obviously, I really would love to know more about this. I understand the gist of it.
Yeah.
But I would love for somebody to explain what. Go for it.
Dr. James, Dr.
May I ask
James.
a question?
Yes.
If you go back to the previous slide,
Mhm.
under the left-hand side, where does clearing the, like if somebody comes in with a seat collar, for example, for neck protection, where
Okay.
does that kind of go under that? Like,
So I believe that if there is a C collar involved and you do not know the stability of the patient,
Yeah.
this
So you
does
can't
not
make
fall
that-
under that
okay.
at all. You will be doing a radiograph right away because you don't know if this patient has that stability or not. If that is the case, you go straight to radiograph because typically it would fall under this portion of the rule, though it's not stated. But you are correct. Yeah. So here we've got, let's see, here we got Nexus versus CCR. And in 2003, a study was performed to put these two risk assessments to the test to see which one was a better fit for the evaluation of acute spinal trauma. Now, this study was done by Stahl in 2003, and it was conducted in 9 different hospitals in Canada. In those 9 different hospitals, they used 8,283 patients. Out of those 8,283, 169 of them had clinically significant cervical spine injuries. Now, the study showed that the Canadian C-spine rule had a more sensitivity than the Nexus rule, 99.4% versus the 90.7% of the Nexus. It also showed that the test was more specific than Nexus, 45.1% versus 36.8%. This did conclude that out of the 169 patients that came back with a cervical spine injury that was significant, one of them was missed by the CCR compared to the 17 that was missed by Nexus. Now, who wants to explain this? Anybody?
I can help
Anybody?
explain.
Go for it.
You
Go for
can
it.
jump in because I always have to stare at this chart for a while. and
I know that
explaining
it does come up in your board exams,
It
and I
does.
did have a colleague that said, "Hey, this comes up on their board exams. See if they want to tell you about
Yeah.
it." So
It
that is
comes
what.
up, yeah,
Yeah.
like in medical school and like
Yeah.
board exams. But so essentially, sensitivity,
Mhm.
looking at of all people who have the condition that or disease that you're investigating, who tests positive with the test that you're using, and then specificity is looking at of everyone who does not have the disease or does not have the condition, like this chart is mentioning, who tests negative. And the goal obviously is to have a high sensitivity and a high
Right.
specificity to have a good test.
Obviously, the higher that both of them are, the better it is, the
Yeah.
more accurate the test.
So both of these tests have actually quite a bad specificity.
They
They're-
do.
Yeah.
They really do.
And I'm not sure if you like interpret that 45 versus 36 is really helpful. Correct me
Yeah.
if you guys disagree, but I feel like just those numbers, like I wouldn't say that either of those tests are specific whatsoever.
Right. Now, the only comparison that I can make with this is because I work with a clinic that does COVID tests all the time, and I just know the sensitivity and specificity of these COVID tests. And I knew that was 75%, which means a 1 in 4 of a false negative. And when I was thinking about that and looking at this, I didn't like that difference.
No, it's-
But I knew that because it was so sensitive, that you would at least not miss anything
Yes.
that was too critical.
And I think they're all having the same discussion.
Yeah.
Ideally for a screening test,
Mhm.
you just want a really high sensitivity because you don't want
Which is exactly what we
miss
have
anything.
here.
Versus a confirmatory test, then you want that
High
specificity.
specificity.
Yeah.
You don't want to miss.
Now in
That's
spin,
exactly
right?
what we're talking
Now
about.
in spin.
goes in and sensitivity goes out.
Dr. James.
So now we have a CT that was done after the risk assessment. So after the risk assessment criteria has been completed, this patient may be sent for imaging. Now in the image above, courtesy of Guarnieri, we have a 20-year-old who came into the emergency room department post-motorcycle accident right away. Because it's a motorcycle accident, it falls under the category of needing imaging no matter what. So we see here image A through D, and that is a multi-detector CT. We see a traumatic fracture of the C6 right here with spondylolisthesis and what we can only assume is going to be spinal cord compression, even though we can't see the spinal cord anything because of how bad this is. Now, if this fracture were not as severe as we see here, we wouldn't know if there was any spinal cord compression, but we do have an MRI that is not the best quality. However, it does show that with the comparison, a little bit more difficult to see, so I did add some red arrows in there to kind of show where that spinal cord compression is. But it shows the confirmation of the C6 fracture. On top of that, it'll show the spinal cord compression here, here, and here. And it shows that the diagnosis that you guys made, the CT was correct, however, still couldn't see that spinal cord in that first image. This is post-operative, same patient. We see that the image, the alignment of the cervical spine for post-procedures, we've got a severe hyperintensity and signal amplification here through here. This is C3 through T1. And next we've got, now we're going to go ahead and go into thoracolumbar spinal traumas. So let's see, I am not missing something, it's right here, okay. So for the thoracolumbar spinal trauma imaging, multi-detector CT is the best option, and that is because we are looking for mainly spinal fractures, which is bone abnormalities, but while it is more uncommon compared to cervical spine injuries, thoracolumbar injuries are also associated with injuries to the chest and abdomen. So after we do the CT, it is warranted that we take an MRI to make sure that the internal organ is also intact and there isn't anything else going on. Now let's look at evaluating some thoracolumbar spinal injuries after a motor vehicle accident. So here we have an image of courtesy of Guarnieri again. We have a 30-year-old male after a motorcycle accident. CT was done, and it shows a traumatic burst fracture of the L1 with, which is right here with a posterior fragment. You can see the traumatic burst fracture here and here. And we also do see that dislocation going into that spinal canal. Now in picture E through F, we have the MRI of the same patient. And here we see the same exact things that we do up here, but we do see a moderate spinal cord injury associated with this on top of that burst fracture that's shown in the CT. So we could have seen the exact same thing we saw in the CT if we had spent that extra 10 minutes to do the MRI, but on top of that, we would have seen the spinal cord compression. Is that recording? Yeah. Mm-hmm. Okay, cool.
Yeah, it's still recording.
All right.
Was I supposed to hit play?
Now this next one I actually added yesterday because I thought this was a really interesting case. As I was about to go to bed, this popped up, and I think this would be something that you guys would like to see. So this one is a domestic abuse case. It was also done on a case study by Guarnieri, published by the British Journal of Radiology. Now, this is a 77-year-old female after a domestic abuse comes in for back pain. Gets a CT right away. The CT shows nothing. You see the kissing with the degenerative discs, but that's about it. That's all normal. Patient is sent to physical therapy. After physical therapy is over, she comes in stating that she has no improvement. So they do an MRI. In the MRI, you see the mandible A1 fracture with bone marrow edema on T12 and L1. Here and here, and here and here, and here and here. Which did not show up in the original CT, even though CT is perfect for bony abnormality. Now, in figure E through F, we see that it was treated with vertebroplasty, and patient was done with physical therapy post-vertebroplasty and came back with no pain. So, to conclude, it's really important for us to definitely do risk versus benefit. Check out the risk for knowing what modality to use and what we could be doing if we use the wrong modality, and how the diagnosis will change the way we treat this patient, especially as we saw in that last image. We also really want to recognize how different it is when we have kids and pregnant patients as opposed to our adult patients who are having normal anatomy and don't have to worry about a second patient there inside. Now, we're also wanting to see the difference between bony abnormality and ligament, tendon, and spinal cord injuries. And if I could bring this down to this whole presentation to the smallest way of talking about it possible, this point right here would probably be the most important. If we can figure out our differential diagnoses, or even bring the differential diagnoses down a little bit, we could easily be able to figure out which diagnostic tool we would want to use. If it is difficult to bring down the differential diagnoses, which sometimes it is, most often it is, especially with evaluation of acute spinal trauma, we would want to go ahead and use the MRI just because of the detail that we would see in our images, as we've seen in all of these case studies when we're comparing these two image modalities. Now, see, there's a lot of different ways to creating a guideline for the evaluation of acute spinal trauma. It all has to be on a case-by-case basis. And I think that if you guys can get that hands-on ability to be able to use this knowledge and add it into seeing patients that you do with acute spinal trauma, it would help you greatly to be able to diagnose them properly the first time and not have to deal with them having to possibly return. So, thank you very much, guys.
Thank you.
Anybody have any questions?